I'll be presenting a case of a 24-year-old boy who presented to our OPD with complaints of weakness of all four limbs for last 1 month, rash over face, arms, and hands for 1 month. So the history of presenting illness is that he was in his usual state of health since 1 month when he noticed weakness in legs in form of difficulty in standing up from sitting or squatting position, and this weakness had gradually progressed over last 2 weeks, such that he noticed difficulty in climbing stairs and walking uphill. He also noticed difficulty in wearing turban and lifting heavy objects. This was associated with mild pain in proximal arms, thighs, and buttocks. Along with this, he also reported slight difficulty in swallowing, which was particularly more to solid food as compared to liquid food. He noticed swelling and redness over periorbital area. He also observed redness over both his arms, forearms, and over knuckles. The rash was painless and it was associated with mild itching sensation. Along with these symptoms, he also experienced excessive itching sensation over the scalp. However, there was no rash over the scalp. Over last 2 weeks, the rash had become more extensive and obvious. And in negative history, there was no history suggestive of autonomic involvement or sensory involvement. And history-wise, there was no history or suggestive of distal or axial muscle involvement, and no facial, bulbar, or extraocular muscle involvement. There was no history of joint pain, fever or Raynaud's, and there was no history suggestive of ILD like dry cough or shortness of breath. And there was no history suggestive of any other connective tissue disorder. So on examination, vitals were normal and the systemic examination was normal except for general examination, which was suggestive of symmetric pitting pedal edema. And these are the photos of the rash. So we can see here that the heliotrope rash is seen. Apart from that, he had other classical rash suggestive of dermatomyositis like Gottman sign, and he had erythema with scaling over the arms also, which is known as sleeve sign. So, neuromuscular examination. So, the higher mental functions was normal. Cranial nerve examination was normal, and the sensory examination was also normal. In motor system, power was reduced, and the tone was normal, and deep tender reflexes were normal. So, this is the MMT8 scoring for this patient. So, as we can see that there is predominantly proximal muscle weakness, and there is some amount of weakness in distal muscles also. So, the MMT8 score for this patient was 111, and the cutaneous dermatomyositis area and severity index score. So the patient had activity, predominantly activity, and his score was 15, and there was no damage at this point of time. So these are the labs for this patient. As you can see, inflammatory markers are elevated, ESR and CRP are elevated, and CPK is elevated. So given the classical picture of dermatomyositis and peripheral edema, and some amount of distal muscle weakness we had already predicted, and the antibody to be NXP2, because there was peripheral edema and distal muscle weakness, which is classical of NXP2. So the myositis lia was suggestive of NXP2 positivity, and because the patient had NXP2 positivity, which is a risk factor for malignancy, and and male gender being also a risk factor, and absence of any protective factors like Raynaud's arthritis or ILD, the patient fell into a high risk category for malignancy screening. So we did a PET scan for this patient. However, fortunately, there was no signs of malignancy. And with the diagnosis of dermatomyositis, we started the patient on prednisolone, 1 mg per kg for a month, and then tapering doses, and methotrexate, hydroxychloroquine, and topical steroids. So patient came back to us after 3 months. So after adequate physiotherapy and proper treatment with proper compliance, the patient did not have improvement in muscle weakness. However, his rashes had significantly improved. So her CDASI score had reduced to 2, but MMT8 score persisted to be low, and it was 108. And CPK levels also remained to be high. So, in view of refractory muscle disease, we decided to give rituximab to this patient, and after appropriate screening, patient was given 2 doses of rituximab. So, however, after 3 months of rituximab therapy and continued physical and occupational therapy, patient had persistent muscle weakness, and he complained of difficulty in walking with inability to elevate left foot, and he also complained of pain over left foot. On examination, the patient had steppage gait, and there was complete loss of dorsiflexion and eversion at left ankle. However, ankle reflex was present and sensory examination was normal. So this time also MMT8 score, muscle activity continued to be low, and MMT8 score was 102 by 140. And so this examination findings are suggestive of foot drop, And because the patient had proximal muscle weakness, also we went on to do an MRI for this patient to see what is the status of the muscle, what is the status of myositis component. So these are the MRI findings for this patient. We can see that there is diffuse myofascial and myoedema in the proximal muscles and also in the distal muscles of forearm and in the distal muscles of leg. So this distal muscle involvement is more common with NXP2 than with NXP2 negativity. So but however, this myofascial edema was not very in proportionate to the weakness that he was having. So we also suspected some neuropathic process, and we got nerve conduction studies done for this patient. So these are the results. So we can see that in left peroneal nerve, the amplitudes are lesser compared to the right peroneal nerve, whereas the latency is preserved. So this is the axonal involvement of motor nerve, and these are the sensory potentials. So we can see that snaps for sensory potentials for superficial peroneal nerve are not recordable. So this nerve conduction studies were suggestive of left sensory motor common peroneal neuropathy of axonal type because amplitudes are decreased but velocities and latencies are preserved. So this was an associated neuropathy. So to establish the cause of this neuropathy, whether it was linked to dermatomyositis or not, we offered a biopsy to this patient. However, he was unwilling for the same. And in view of refractory disease, we started the patient on monthly IVIG therapy. And after 3 doses of monthly IVIG therapy, the patient had shown significant improvement. His MMT score has improved to 120 out of 140. And power at ankle dorsiflexion flexion has recovered from 1 to 4. So just a brief reflection of the timeline of this patient. That in November 2022, patient had all the classical skin signs of dermatomyositis along with muscle weakness, and he was started on glucocorticoids, methotrexate, and HCQS. In March 2023, patient came back to us with persistent weakness, and in view of refractory disease, rituximab was given. However, even after 3 months of rituximab and adequate physiotherapy, the patient had persistent weakness, and this time he had presented with a new complaint that was of foot drop. So we started the patient on monthly IVIG, and after 3 months of 3 cycles of monthly IVIG, the myositis path has also improved, and there is improvement in foot drop also. So, reviewing the literature that how common is neuropathy in myositis, we did a literature search, and we first of all, speaking about NXP2 dermatomyositis, that NXP2 dermatomyositis can itself cause distal muscle weakness. So this paper reflects that NXP2 positivity is associated with distal muscle weakness compared to NXP2 negativity. And then speaking about the neuropathy, speaking about the associated neuropathy, so this was a case report in which a patient of dermatomyositis had a neuropathy. And when they did a nerve biopsy, the nerve biopsy also showed MAC deposition. So MAC deposition in muscle and MAC deposition in nerve as well. So this reflects a unifying pathogenesis. And another case report we had seen where a patient with Rho52 and MDA5 positivity dermatomyositis had developed a peripheral neuropathy, a mononeuropathy. So, till date, 12 cases of dermatomyositis with neuropathy have been reported, and all these variants are of axonal type, reflecting some vascular. And just talking about the treatment part, many of them have improved, whereas some of them continue to have persistent neuropathy. And this is the basically this group studied nerve conduction abnormalities in all the patients of dermatomyositis, and they found that even though the patient does not have peripheral neuropathy, they do tend to have abnormal nerve conduction studies. And there were all the kinds of peripheral neuropathy were possible, from polyneuropathy to multiple mononeuritis to carpal tunnel, and then ulnar sensory neuropathy. And brachial plexus involvement was also has also been reported. And the patient also had significant scalp pruritus, and there was no obvious rash on examination. So this paper reflects the importance of small fiber neuropathy, which leads to intractable scalp pruritus. So in the diagram below, we can see that in a control patient, the epidermal nerve fiber is preserved, whereas so the epidermal nerve fibers are preserved, whereas in a patient of dermatomyositis, the density of this epidermal nerve fibers is reduced drastically. So this also suggests that there is small fiber neuropathy in dermatomyositis patients, which is probably responsible for intractable scalp pruritus. And this suggests that there is some amount of neurological peripheral nerve involvement in dermatomyositis as well. So I'd like to conclude my session with the points I would like to highlight. So NXP2 dermatomyositis is characterized by severe muscle weakness, as was in our patient, peripheral edema, calcinosis, distal weakness, and malignancy risk. And then intractable scalp pruritus can be due to small fiber involvement. Nerve conduction abnormalities are frequent in dermatomyositis, whereas peripheral neuropathy is less common and less explored. Particularly speaking about NXP2 dermatomyositis, there has been